I'm Dr. Velavan, Associate Professor at Samdan College, Ramapuram. Today we're going to talk about Ankyloglossia, tight tongue. As the picture represents, the kid is having an protrusion of the tongue with a difficulty. So, what is Ankyloglossia? More than a string, just a string, a condition of a limited tongue mobility caused by a restrictive lingual frenulum, a tissue remnant located in the midline between the tongue's ventral surface and the floor of the mouth. As the picture represents, there is an attachment of the string or an frenulum at the ventral surface of the tongue. What is the clinical principles? If the function is impaired, it is symptomatic tongue tie. So there can be frenular attachment, high frenular attachment for all the patients, but when the function is restricted, it is considered to be an ankyloglossia. What is the reason for ankyloglossia is not clearly said, but the hidden epidemic is this condition isn't new, but rapid evolutionary changes in human facial structure have exacerbated oral restrictions. So, as one picture shows, the ancient skull was having an advanced mandible or an comparatively a prognatic mandible than the recent skull, modern skulls, where the jaws are retracted and the narrower arch has been formed. So the structural shifts over the time must cause the reason for this, thought to be the reason for this ankyloglossia. So what are the symptoms? The signs and symptoms of tongue tie will be the difficulty in lifting the tongue to the upper teeth or moving the tongue from side to side, trouble sticking out to the tongue past the lower front tooth, a tongue that appears notched or heart shaped when stuck out. Like the picture shows, almost the kid is having an heart shaped tongue where the tip of the tongue has been blunt and it looks like a double tips. So it is by two tongues, it looks like a two tongues where the bifid tongues, what we call as a bifid tongues, where you have a small depression in the tip of the tongue. So what are the problems usually these causes caused by this high frenulal attachment on the or the lingual frenulal attachment? The problems will be maybe having trouble breastfeeding, speech language pathologists might be think the child's speech is affected by the tongue tie, or the child tongue problems that interfere with eating, speaking, or reaching the back of the teeth, and even kissing. So these are the problems when will occur when the patient is having an ankyloglossia. So what are the complications? Tongue tie may affect a baby's oral development as well as the way the child eats, speaks, and swallows. For example, the tongue tie can sometimes lead to breastfeeding problems. The breastfeeding requires a baby to keep the tongue over the lower gum while sucking. If unable to move the tongue, it will interfere with the baby's ability to get breast milk. Ultimately, poor breastfeeding can lead to inadequate nutrition and failure to thrive. And then you can be having then speech difficulties. As the age advances, the patient will be almost having an childish speech or the pronunciation which cannot be made clearly. So they identify with the ability to make certain sounds such as T, D, Z, S, the, N, and I. So the poor oral hygiene for an older child or adult, tongue tie can make it difficult to sweep the food debris from the teeth. This can contribute to tooth decay and inflammation of the gums. So challenges with other oral care activities like tongue tie can interfere with activities such as licking an ice cream cone, licking the lips, or playing a wind instrument. So these are the things which will be difficult for the child as it grows to an adult. So these are the problems we can encounter. So usually tongue tie will be playing a major role in feeding of the child. As the child advances, there can be speech difficulties. The kid can have an poor oral hygiene, and also can have a challenges with the having the functional movements or functional habits. So there's a big debate between why diagnosis is difficult. The conflict is traditional you treat only the physically bound to the tip anterior, and the modern view treat if there is a functional deficit in feeding or speech, even if submucosal. So what is a myth versus fact is myth it's just a lisp. So it is a functional restriction affecting feeding, swallowing, breathing and dental development. But there's a stretch it out. The frenulum is a facial X tissue. It does not stretch. Symptoms merely shift. So the usually what is mean is there is a problem, but the problem is not going to be addressed. The adjustment can be happening that the child can alter their way of eating, their way of speech, everything they can alter, but still the problem exists. So usually don't consider that it will heal by itself. It is altered. It is not healed or it is altered. So the basic function has been altered or adjusted by the kid by himself. So impact on childhood versus adulthood. A tongue tie doesn't go away. The symptoms just change form. So like previously I said, tongue tie doesn't go away until it is interfered, but the symptoms just change form. So speech and articulation, difficulty with sounds requiring tongue elevations, especially S, Z, T, D, L, R, that are the things. The mechanical function is the inability to lick lips or eat an ice cream cone cleanly, difficulty performing tongue tricks. The kids will not be able to do the tongue twisters, discomfort or cuts under the tongue from the lower teeth because he couldn't protrude the tongue freely. The tongue will be in very close approximation of the lower tooth and it can get injured in the ventral surface. Based upon social and dental, mouth breathing habit can be there. So these are the after effects of this, but the kids will not be understanding or they will not be having a major problem, but they would have a continuous form. So the later effects will be like mouth breathing habit, dental malocclusion, class 3 underbite, gingival recession. These are the things we can see it. So what is the basic thing is in ankyloglossia or the tongue tie, you should understand that visible symptoms will be the breastfeeding struggle, lisp and the gap between the teeth. But the systemic effect like an iceberg which is underneath this ocean, the systemic impact will be sleep apnea, mouth breathing, facial development and the posture. So these all will change on the long run if this is not addressed. So ankyloglossia is not addressed, these are the things it will affect. So the artifact of the architect of the face is tongue is a nature's palate expander. Low tongue posture caused by a tie exerts downward pressure, potentially leading to mandibular prognathism or underbite and the maxillary underdevelopment. So these are the after effects of a tongue tie. So the tongue tie might be looking as a simple or a common condition, but the after effects are very high. So how you go to treatment of this is like I said, multidisciplinary team. Surgery is not a silver bullet; it requires a village. So like what is the thing is it needs a team of peoples to treat the tongue tie. So first it will start with the consultant, lactation consultant, who assesses about the milk transfer and the latch. So next will be the release provider. So we can consider as a dentist or a ENT who performs the frenotomy or frenectomy to the kid. So until otherwise it is addressed, the tongue tie will not go by itself as the age advances. And next will be the speech therapist who will be talking about the neuromuscular re-education and articulation for the kids so that the pronunciation will become very good for the patient. And then the person who talks about the addresses the body tension and the torticollis are the kids aged peoples who will be addressed by them. So comprehensive care requires collaboration across these disciplines to ensure lasting results. So how you say about an classification of Ankyloglossia? Free tongue length is a major thing which has been said by Lawrence Kotlow. So free tongue length of the tongue from the insertion into the base of the tongue and to the tip of the tongue. So the attachment measurements is basically the thing which will tell you about the condition of the ankyloglossia. So tip from the tip of the gingiva to the tip of the tongue, the attachment from the gingiva to the tongue will be measured. If it is more, it becomes less ankyloglossia. If the length is less, the class of ankyloglossia becomes more. So based upon that, if the measurements is 12 to 16 mm, it is called as a mild ankyloglossia. So whenever there is an the tongue freement of the tongue is more than 16 mm, it is considered to be normal. So when it is going to be 12 to 16 mm, it is mild ankyloglossia. 8 to 11 it is a moderate ankyloglossia. 3 to 7 it becomes a severe ankyloglossia, and less than 3 mm is the complete ankyloglossia. So in the pictures you can see the free movements of the tongue. So if the person can move the tongue tip or touches the incisal in lingual surface or the palatal surface with the tip of the tongue, it becomes the free tongue. Okay, the free movements of the tongue is that. So this is based upon the tongue range of motion ratio TRMM MR, based upon the anterior tongue mobility and the tongue to incisive papilla. So this is the measurements which is graded. This is the grading of the thing. So this is another classification. So when there is a movement is greater than 80%, it becomes a grade 1. If it is 50 to 80%, the patient can move the tongue inside, but they cannot touch the palate or the tip of the incisors. It becomes 50 to 80. When the person cannot raise the tongue completely towards the palate, or not even above the closer to the palate, it becomes less than 50%, it is grade 3. And the person cannot raise the tongue at all, and it forms an heart in shaped tongue tip. It becomes, that is, the movement is less than 25%, it becomes grade 4. So you can see the tongue movements, free tongue movements. So how you do the assessment? A function over appearance. So appearance is not a problem for the ankyloglossia patients. Only thing is when there is a functional deficit, it becomes a gold standard. Okay, so function is the gold standard. So appearance is not a gold standard. So Hazel-Baker assessment tool for the lingual frenal attachment was based upon two things. One is anatomy score and the function score. Assessment requires active lifting and movement analysis, not just visual inspection. So if the person or the patient can move the tongues, it becomes easy. If the function score is 14, it is perfect. So there is no need for your any surgical intervention for the patient. But if there is a less score of 11 or less, the function is impaired. It considered the function is impaired, and the intervention is recommended. So this is the scoring system, Hazel-Baker assessment tool for lingual frenal function. So first will be the appearance of the tongue when lifted, elasticity of the frenulum will be checked, length of the lingual frenum when tongue lifted, attachment of the lingual frenum to the tongue is done for the appearance wise, and for the functions items it will be lateralization, lift of the tongue, extension of the tongue, spread of the anterior tongue. So these are the things, and along with that, in anatomical this we will check for the attachment of the lingual frenum to the inferior alveolar ridge, that is the incisor tip, lower incisor tips. In functional, we will go for cupping, peristalsis, and then snapback. So these are the functional score based upon that. So on the right side you have the functional score, and left side you have the anatomical score. So anatomical score goes with 5 points, and for your functional score, it goes around 7 categories where the score points, maximum scores will be 2 for each one. So 2 into 7 it is 14 the maximum score, and 5 into 2 it is 10 the maximum score for the anatomical positioning. So how you treat it out is the gold standard things we have to think about in frenal attachment. Either you can go for frenotomy if the is a very infant or a child. We can go for a frenotomy. Simple incision, snip of the frenulum can be done, common in infants. From frenectomy, release with the repositioning or repair of the tissues, common in older children and the adults. So basic myth is that it resolves on its own, but fact is that observational resolution is often just the child maladapting their swallowing pattern. Myth, it is high risk. The fact is bleeding or complications are rare when you are doing this frenotomy or frenectomy procedure, and the procedure typically takes seconds. So this is a patient we have operated on. So this you can see the high frenal attachment. So from the gingiva, there's a small tissue which is attached to the tip of the tongue. So here the tooth movement was in the grade 3, where the patient can move it up, but he cannot go and touch the completely the tip of the tongue or the tip of the tooth or the palate. But if he tries to do, he cannot open the mouth. So this is the difference. So this is an older child. So it means he is around 12 years old. So what is the difference between an infant and this will be he has got to an adaptive functions. So what are the adaptive functions are he can keep the tongue here, but when he tries to touch the tip of the tongue, he can move it out. But only thing is, I will show you a video of it. He will have his mouth automatically closed when he tries to tongue. So tongue is not moved up, but the jaw is brought down to touch the tip. So this is a small video showing the tongue movements which is restricted. He is having a difficulty. See, when he tries to move his tongue and touches the palate, he is not moving the tongue freely, but he is trying to close the mouth so that he can touch the teeth and the palate. So this is the kind of adaptive uh, uh, functions which can be made by the kid before as the age advances. So we are moving on to the surgical procedure of it. So I can show you after I made an in LA local anesthetic injection given on to the lingual aspect of the that's the ventral aspect of the tongue. We made a retraction suture. So bilateral lingual nerve block was given, and also local infiltration was given for the frenal release. So after that we made an retraction suture which was placed over the tip of the tongue for raising the tongue out. Okay, and then we can see the frenal attachment clearly. So the frenal attachment is to the tip of the tongue and to the tip of the to the incisal in between the incisal tip, that is then the gingival aspect. So two hemostats were placed, one over the close to the tongue and one will be almost close to the bilateral. Careful, we have to be very careful about the duct opening, bilateral duct opening of the submandibular ducts opening will be there. So we should be very careful about doing this procedure. We shouldn't harm the ductal openings. So on the bilaterally onto the close to the frenum. So we clamped the lower attachments also with two hemostats, one up and one down. So we make a small wedge like incision over the beaks of the hemostats. After the excision, we will have a small triangular shape or a diamond shaped defect. So after that, the defect is getting dissected. So freeing of the tissues and the mucosa and the muscle is freed in that area. So the mucosa will be easy for us to suture up. So this is the released frenum. So you can see it is undermined and it has been dissected. After the dissection, we have a free space like that, and then the closure of it. So you can see previously the tip of the tongue attachments was very close to this tip. Now it has been freed, and the frenal attachment is at the base of the level. So here you can do the closure so that the attachment has been reattached or it has been refixed from the tip to the base of the tongue. So the primary closure has been done. So you can see the tongue movements after the release. Yeah. So he is not closing the mouth, but he is trying to put the tongue. Yeah. Yeah. So this is the thing. So we had been made into this. So his tip of the tongue has been freed so that he was able to move the movements. Okay. So this is the movements of the tongue, which is after the procedure. So the clarity to the roadmap is basically we should have a clear identification what is the patient having and what is the functional assessment you have done, and how you are going to build the team, how we are going to do the muscle toning, or how we are going to make the patient have a better speech therapy and the thing. So the intervention will be the frenotomy or frenectomy which is to be done, and post this will be active wound management and the therapy. So prior to the roadmap is identifying the symptoms, functional assessment, build the team, then you do the pre assessments, do the intervention, and post rehabilitation. So pre rehabilitation and the intervention and the post rehabilitation will be always needed for the child for a betterment of the life. So with this I'll conclude that from the confusion to clarity. So what is the confusion we usually have, whether to treat the patient or not? So you have to assess the patient. Functionally the patient is having a difficulty or the score less than 11, then you have to intervene the patient, and you after you do the assessment you can go for the treatment, or treatment is going to be gold standard, that is going to be frenectomy or frenotomy, that is done for the infants, frenotomy for the adults or the older child it is frenectomy, and along with that the rehabilitation has to be done. So from confusion to clarity. So what is major is proper identification and comprehensive treatment change the trajectories. So when we untie the knot, we do not just release a tongue, we unlock the potential for the proper breathing, articulate speech, and restful sleep. It is a small string with a massive impact. So don't think the ankyloglossia or an tongue tie is a simple thing. The after effects are always danger and more. Okay. So with this we'll finish it off. Thank you.